welcome you all for our 25th webinar on Prerna. Today, let me give you guys a little bit of an introduction about Prerna. Prerna is a pediatrician and residence education and research advancement in Nepal and America. This is a group created by the pediatricians for the basically advancement of approach in healthcare and how we approach children's care. And we really wanted to promote the education and training to the younger trainees as well as younger faculties and whoever would like to pursue. And today we have our speaker, Dr. Dharmagat Bhattrai. He's not, I think you probably in Nepal, he is already well known by his work that he's been doing in allergy and immunology and rheumatological disorders in children. He has published many articles and presented and given talk to many countries. And I think he has almost visited almost 100 countries. And it's a pleasure to have him as a speaker today. We wanted to do this as a case-based approach and discussion. And please feel free to share your questions on the question Q&A questions there, as well as this will be recorded and you can watch this on your time on our Facebook page, which is KOH Partners of America. And yeah, here you go, Dr. Dharmagat Bhattrai. I will let you share your slide and go ahead with your presentation, please. Thank you.
Thank you so much, Dr. Dilli. I'm really feeling honored to be in this platform. Are my slides visible?
Yes.
Yeah, thank you. Thank you so much. And it's a really matter of pride to present some introductory overview about this subspecialty in Prerna. Prerna is just like name. It is always inspiring platform for all the pediatricians and even for the physicians who are practicing all over the world. So today I am going to give some introductory overview. It is a case-based discussion, but we will also touch some part of the introductory overview about the inborn error of immunity. This is the better name of primary immunodeficiency disease, because previously it used to be called as primary immunodeficiency disease. Now it is better named as inborn error of immunity, and we will be discussing on the case-based approach. I will start this presentation with a difficult case, uh, which was diagnosed after a very long period after the first presentation. This child was brought to me at the age of around 6.5 year, but the symptoms started at the age of around 2 years with enlarged lymph nodes in the body, and tested for tuberculosis and was negative and treated with antibiotics, and later also treated with empirical anti-tubercular therapy. And during that time child had severe pneumonia, and after 1 year of that severe pneumonia case, there was episode of fever, lymphadenopathy, hepatosplenomegaly, rashes, high inflammatory markers, and there was high value of ferritin, CRP, triglyceride, and marrow was showing hemophagocytic lymphohistiocytosis. So at that time child was treated as the infection induced HLH, and subsequently after almost again 8 to 9 months of that episode, child had abdominal symptoms. So if we see the natural history of the disease, there were respiratory manifestations, then systemic manifestation in the form of HLS, then there were gastrointestinal features, and after that child had widespread infectious and inflammatory manifestations in the form of otitis, arthritis, pustular eruptions, and because of the progressive respiratory symptoms, subsequently after many years of initial presentation, child landed up in my OPD. So at the time of presentation, the presentation was can be summed up as high grade fever, respiratory distress, abdominal pain, and back and knee joint pain, and there was significant growth failure in the child. As we can see in the pictures, there were distinct evidence of vasculitic rashes, erythema nodosum, and there were multiple fluffy nodular opacity in the bilateral long feet, giving the tree in body appearance. So it was looking like a riddle wrapped in an enigma, because there were so many systems involvement, and there were so many presentations, so it was grossly confusing. So at the beginning, when we think in the organ based differentials, we can think about disseminated tuberculosis, complicated pneumonia, polymicrobial infection in a child, or celiac, different presentation of celiac disease, and inflammatory bowel disease, complicated JIA, infection induced HLH, and so on. But yes, these are there. But if the child is continuously having these kind of infectious and inflammatory presentations, so at that point, probably we should think further, because these diagnosis of tuberculosis, diagnosis of colitis, diagnosis of HLS, and all these presentations may be presentation of some complicated single diagnosis, and these may be the part of that complicated disease. So what can be that disease? That that should come to our mind if there are recurrent or persistent symptoms, like in this case. So at the time of presentation, probably if we look back on the history at the presentation around 3 year, probably we can think about whether it is malignancy or it is immune dysregulation or immune deficiency, because there is no other single diagnosis which can explain all of these manifestations. So we investigated the child, and there were multiple different findings like anemia, leukocytosis, there was neutrophilia, platelet count was almost normal, and inflammatory markers were raised, galactomannan index was also high, and in bone marrow biopsy, we only got reactive changes at the time of presentation, but in the past, there was a history of HLH also. And the skin biopsy showed the frank evidence of leukocytoclastic vasculitis, and endoscopic examination showed inflammatory colitis, but there were no evidence of telltale evidence of celiac disease. And long FNAC was done, and which showed granulomatous inflammation in the gross examination, but the biopsy culture showed the growth of Aspergillus nidulans, which is very infamous to cause infection in the primary or secondary in immunodeficient patients. So we investigated the child for the immunological test, and ANA was 2 plus positive with the coarse speckled pattern. ENCA was negative. Rheumatoid factor, because of presence of arthritis, we also tested for RF and anti-CCP. These were negative. Fecal calprotectin, which signifies the bowel inflammation, was high, and anti-TTGA was not very high, but immunoglobulin level IgG and IgA, and also IgE was mildly elevated, signifying probably some extent of inflammation, and lymphocyte subset assay was normal. This here we can see that even with the high level of immunoglobulins, which can occur in the inflammatory states, patient can have some immune dysregulation or immune deficiency. So what can be the diagnosis at such a point? So we had the possibility of combined immunodeficiency, phagocytic defect, activated PI3 delta kinase syndrome, interferonopathy, autoinflammatory disorder, malignancy, and so on. But even if we do not have any clue about the definite immunological diagnosis at this point, we can at least think that these many systemic manifestations can only occur if there is some underlying severe genetic defect or immunological defect or some kind of lymphoproliferative or malignant disorder. So for proving it, we started with the easiest test that is available now, currently available in Nepal, which is started by me only because this is not done in the commercial lab. The nitroblue tetrazolium reduction test. It tests for the oxidative burst assay, and as we can see, there is a gross difference between the patient and control, and it proves that this is consistent with CGD. And subsequently, we were successful to send the genetic test, and it shows pathogenic homozygous loss of function mutation in the CYBC1 gene. This is one of the gene to cause chronic granulomatous disease, which is very common disease, but among the different genes which are responsible to cause chronic granulomatous disease, this is one of the uncommon gene, and it is also reported from our team. Basically, this case highlights that when the patient has multiple multisystemic presentations at the different time period, and different kinds of presentations are present in the same patient at that time, we must think about the root cause of the cause which can explain all of the manifestations that is happening in the patient. Subsequently, I also want to highlight in this kind of patient, for the investigation, it takes a huge amount of money. So logistic constraints and lack of awareness of invulnerability of immunity among the laity and the physician account for the missed and late diagnosis and poor outcome. This kind of patients sadly mostly remain undiagnosed because of the lack of awareness, because not only in Nepal, but also even in the developed country, in some part outside the immunology centers, this kind of patients, if we do not think about the different underlying possibilities, most immunodeficiency cases go undiagnosed. So uh, um, when we talk about immunodeficiency, I generally see a kind of concept in among the general public. I had conducted an internet-based essay also. At that time, I found the concept like primary immunodeficiency. Do they really exist in the developing countries? Like there is no reports from most of these areas. So here, I want to highlight that when we think about these disorders, these are there. It's just like we are palpating the different parts of elephant. We are very familiar with this story. So when we come to the diagnosis, certain diagnosis, we generally become fixed to that diagnosis. Oh, this is pneumonia, this is enteritis, this is allergy, this is cytopenia. But if this is recurrent or persisting, or if multisystemic manifestations are occurring in the same patient, we we should probably explore the history further, and we should think like the diagnosis we made may be a part of a bigger diagnosis or some underlying bigger cause. So that cause may be immunodeficiency, immune dysregulation, or malignancy. And most of these disorders remain undiagnosed because of the multiple reasons, because they are heterogeneous, because we cannot define the pathognomonic feature of some immunodeficiency, because that is very complicated. And most of the disease have definite clue for the diagnosis, but we cannot pinpoint, or we cannot say that this particular symptoms or this particular taste is always pathognomonic. But there are definitely exceptions, like for this case in the CGD, if you have DHR and NBT, nitroblue tetrazolium test, these are consistent with CGD, then you don't have any other option. You must you have your diagnosis even without genetic test. But in most of the other invulnerability of immunity, it is always difficult to pinpoint only with the symptoms, only in the clinical presentation. And mostly these diseases are multisystemic with the obscure etiology, and there are confusing and overlapping features. And basically, low index of suspicion is another main reason we miss this kind of disease in the most of the patients. If we look upon the development of this universe of immunodeficiency, it is gradually developing, and over the period of 6 to 7 years, the number of invulnerable of immunity is increasing from the figure of 300 to now almost 570. In 2022, this publication from IUIS, International Union of Immunological Society, has published 485 known genes resulting into invulnerable of immunity, and now it has increased almost in the range of 570. This universe is always expanding, and there are many different immunophenotypes described in the different kinds of disorders, in different kinds of like missense mutation, deletion, duplications, and many other different kinds of genetic defect defining invulnerable of immunity. If we see this chart from 1980 to 2022, this number of increasing number of genetic defects are gradually increasing in the very fast rate. And this is the representation of number of patients diagnosed within our country after 2020. These are the different 10 categories defined by IUIS among the invulnerable of immunity. These are different: cellular immunodeficiency, humoral immunodeficiency, antibody deficiency, immune dysregulation, phagocytic defect, and so on. So, if we summarize this finding, we can say that the frequency of invulnerable of immunity is between 1 in 500 to 1 in 10,000. It depends upon the awareness that is present in the different country, and level of availability of diagnostic and therapeutic modalities, and clinical manifestation of PID, primary immunodeficiency disease, may evolve over several years. It does mean the primary immunodeficiency, they need not, they do not present always in the childhood. They may present in the adulthood. For example, common variable immunodeficiency may present in the adulthood, and even chronic granulomatous disease, MSMD, this kind of disease may present altogether in the adulthood only. And disease like hereditary angioedema due to C1 inhibitor deficiency, they may present in adulthood, not in the child age. Inherited and usually monogenic defect resulting in the deficiency of immune function, and populous country have the large number of II, like for example India, they have reported large number of invulnerable of immunity because of the lack of diagnostic facility and affordability of the patients. Most of the underdeveloped country have underreported this disease, and they need not always present with severe infection, because some of the invulnerable of immunity or primary immunodeficiency disease may present with the very mild infection, like for example selective IgA deficiency. In the beginning, to know the warning sign of primary immunodeficiency, Jeffrey Model Foundation, one of the foundation that is working for the benefit of immunodeficiency all over the world, has given 10 criteria to diagnose immune deficiency in children as well as in adult. For the children, they have defined different numbers of ear infection, sinus infection, number of pneumonia within 1 year, and failure to thrive, deep-seated skin and organ abscess, and persistent thrush, need of IV antibiotics every time during infection, and deep-seated infections, and family history of primary immunodeficiency disease. And similarly, for adults, the frequency of infection is lower. Like even with less frequent infections, should raise the suspicion of presence of immune deficiency in adult as per Jeffrey Model criteria. But Jeffrey Model Foundation criteria only focuses on the infectious part. Gradually, we understood that immunodeficiency does not only predispose to infection; it also predisposes to different other kind of non-infectious symptoms. Apart from the recurrent infection, severe infection, unusual pathogen, and restricted pathogen pattern, we should also be aware for autoimmune cytopenia, lymphoproliferation, eczema, skin lesions, endocrinopathy, enteropathy, any kind of multisystemic non-neoplastic recurring lesions or any kind of persistent lesions or any kind of periodic symptoms like periodic fever or any other kind of manifestations, these may be warning signs of inborn error of immunity. So currently these comprehensive warning signs include all those non-neoplastic recurrent local or systemic issues. So in these kind of presentation, we must think about primary immunodeficiency or inborn error of immunity. Now, as we are focusing this discussion on case-based discussion today, I would also like to add another case, case two. This is the case of 5-year-old boy born of non-consanguineous marriage, symptomatic since the age of 4 months, with multiple episode of infection, growth failure, multiple admissions, recurrent episodes of pneumonia, boils, suppurative otitis media, recurrent bleeding episodes, and on examination there was significant wasting, eczema, multiple vasculitic rashes as you can see in the picture, and ecchymosis, healed scars, lymphadenopathy, colitis, and enterorrhagia. Because this presentation was quite familiar and because there were presentation of infection, skin lesions, and bleeding episodes, thrombocytopenia, I had the strong suspicion of Wiskard-Eldridge syndrome or some kind of actinopathy that can lead to this kind of disorder. So I investigated on that line. I found persistent thrombocytopenia in the records and at the time of presentation with anemia and normal mean platelet volume. This is quite noteworthy. Though Wiskard-Eldridge syndrome can present sometimes unusually with normal MPV, but finding normal NPV is odd point for Wiskard-Eldridge syndrome in common. Now, there were also raised ESR and CRP, but normal total leukocytes and mean platelet volume, and raised IgE and IgA, but low value of IgM and IgG was quite puzzling at the beginning, and ANA was positive, signifying some sort of autoimmune process going on, and normal T cell but slightly raised NK cell and B cells were present, and even further immunophenotyping showed reduced number of CD4 cells and borderline low CD8 cells. And this thing interested me further, and because in the primary immunodeficiency disease there may be some family history, similar kind of family histories. When I explored the family history further, the younger brother who was 4 months old had also the history of blood in stool, itchy rash, eruptions, gastroenteritis, and mild pneumonia, but all these episodes were treated as the isolated episode, like blood in stool was treated as dysentery, itchy rash was treated with antihistaminics, and so on and so. But when I subsequently explored further, they had distinct pictures of that child, which was giving evidence of maculopapular rash, evidence of respiratory infection, organomegaly, and dacryocystitis was also recorded in the medical history. So I called the called mother, and child was brought and subsequently investigated, and this child, second, the younger child, also had the similar kind of immunological finding. So this thing raised a strong possibility of inborn error of immunity, most probably actinopathy, and our suspicion was proven to be correct, and whole exome sequencing proved a very rare kind of actinopathy, though it was not Wiskard-Eldridge syndrome. It is a rare actinopathy, but previously this actinopathy was reported in Nepalese origin patient from Italy. And this was very clicking in the mind, and we could diagnose this patient, and now it is also in the abstracts which is published in Journal of Clinical Immunology, and currently there are many other patients with this defect in the Nepalese origin, patients with the Nepalese ancestry. This is basically a ARP-mediated filament branch defect, resulting into the combined immunodeficiency, autoinflammation, thrombocytopenia, and allergy. The thing which should be highlighted in this history is this child was having these symptoms from the age of since the age of 4 months, and child was suffering for a long time with different kinds of presentation like all allergy, inflammatory symptoms, autoinflammations, different infections, and child was repeatedly admitted in different hospitals, but it was always treated as an individual entity. Like sometimes child was treated as cow milk protein allergy, sometimes treated as colitis only, sometimes treated as pneumonia only. If all these presentations were knit up in the single garland or single thread, then if we had connected these dots, probably we could have thought inverter of immunity. Yes, we may not diagnose the actinopathy in the first go, but we can think about the inverter of immunity if these things are happening from time to time repeatedly in this child. So child would not be admitted 80 times for this diagnosis. So even from this past case, we can think about the circle of immune disturbance. So immune disturbance does not only lead to infection, it can lead to allergy, autoimmunity, inflammation, autoinflammation, and even malignancy. So age of presentation, type of organism or type of infection, and family history, definitely these three things are very important for our history. Because if we think about the cellular immune deficiency, cell mediated immune deficiency like T cell immune deficiency, mostly they present in first few weeks or first few months of life. For example, severe combined immune deficiency. But if it is of hypomorphic variant of T cell immunity, it may present later also. But if we take the example of humoral immunodeficiency, they generally present after 6 months of age, because initially there is uh, some some amount of protection because of the transferred immunoglobulins from mother. So the age of presentation also is also important, and for the cellular immune deficiency, opportunistic infection with the unusual organism is quite common. And in the humoral immune deficiency, we can think about humoral immune deficiency when there is repeated infection with the encapsulated bacteria, even giardia, and sometimes enteroviral infection, though the viral infection is more common in the T cell immunity. So this is overlapping feature. So it's not hard and fast like if there is viral infection, it is always T cell immune deficiency. It's not like that, but in general, we can generalize. So for the phagocytic defect, just for example, chronic granulomatous disease, generally catalase positive organisms are the main culprit for infection, and in the complement defects, Neisseria, encapsulated bacteria are other main organisms. So coming to another case, I would like to present another case with the predominantly immune dysregulation feature. This is the 8-year-old girl born of non-consanguineous marriage again, symptomatic since the age of 4 month, 4 year of age, with the recurrent fever, rash, lymphadenopathy, recurrent GI upset, and recurrent episode of oral ulcer, abdominal pain, back pain. As you can see in the picture, there are distinct telltale evidence of this kind of presentation, and there was significant polyarthritis and eye symptoms also. An examination findings showed overweight, and as you can see, there were lipidoid rashes in the foot and vasculitic rashes in different part of the body, and multiple admissions and diagnosis were there. Like child was sometimes labeled as inflammatory bowel disease, sometimes as JIA, and treated with the low dose steroid only, and sometimes labeled as systemic lupus erythematosus also. So, what is the possibility? In the first go, definitely we will think about the juvenile idiopathic arthritis, systemic lupus, monogenic lupus, inflammatory bowel disease. It's quite common to think about all these diseases. But if the presentation is going on despite giving the drugs, then we should think beyond that. So we again investigated, and it showed anemia and various different kind of total leukocyte count, probably because different phase of disease has different kind of presentations, and platelet count was almost in the higher side, but sometimes very few reports were in the lower side. Inflammatory marker was very high. Ferritin was also high in the in some of the test reports, and fecal calprotectin was also high, and bone marrow biopsy showed reactive changes. Skin biopsy showed evidence of vasculitis again, and endoscopy showed non-specific colitis not amounting to celiac disease in this patient also. And complement level was slightly low. Both C3 and C4 were low, and interleukin 6 was very high, and lactate dehydrogenase level was also high. But other tests like ANCA, fibrinogen, D-dimer, anti-dsDNA were negative. ANA was co-speckled positive with the titer of 1 is to 320 positive, and ENA profile showed mild positivity for SSA and RNP-C. Immunoglobulin level was normal, and lymph node biopsy showed some suspicion of Kikuchi lymphadenitis, and peripheral blood lymphocyte immunophenotyping was normal. At this point, this test has definitely signified towards the possibility of some kind of distinct immune dysregulation going on in this child, because there was mixed possibility and mixed positivity of autoimmune markers, inflammatory markers, and even some disease markers like SSA and RNPC. But this does not signify some distinct rheumatic disease only. Because of this confusion, we thought about some complex disease which can result into all of these manifestations. So we need some diagnosis which can encompass all these kind of manifestation, or which can describe all this kind of presentation. So we thought about the possibility of monogenic autoinflammatory syndrome, which can lead into all these kind of manifestation, or can it be a connective tissue disorder with various complications, or can it be a complicated systemic vasculitis, or mono or polygenic interferonopathy, or it is any unknown inborn of immunity, or it is a initial presentation of malignancy, and we are totally out of clue. So we sent genetic test because there was no evidence of malignancy in bone marrow test and lymph node biopsy also. And this proved that this patient was suffering from A20 haploinsufficiency with the pathogenic heterozygous 2BP deletion in the TNF-AIP3 gene. It is a very well-known mutation that causes haploinsufficiency in A20, and as when we diagnose this distinct disease, we treated with the targeted therapy, including anti-TNF agent and other supporting drugs, and patient subsequently improved. If we see the initial diagnosis of A20 haploinsufficiency throughout the world, most of these cases are initially labeled as Behçet disease, inflammatory bowel disease, GIA, PFAPA, CDN, like this. So it's very common to label these kind of patients as some other entity, and it's not very uncommon. But just a take home point from this case is that if we have some patient with various different kind of presentation, and that is persisting despite giving different kinds of drugs in the patient, then probably we should think about the definitive diagnosis which can explain all kind of presentation, and which can also explain the non-response of the drug that is given for the diagnosis of one entity, just like JIA, or just like Behçet disease, or something like that. So occurrence of various if we see the occurrence of various symptoms in the systemic autoinflammatory disease, we can find a range of symptoms or range of presentation like recurrent fever, skin lesions, vasculitis, GI ulcer, kidney injury, liver injury, and so on. So there is a huge list of this kind of presentation. So if we find different multisystemic presentations over the period of time, persisting or recurring, or it is coming in the periodic pattern, or it is associated with the infection as well as inflammatory features, then we should probably think about, or we should keep systemic autoinflammatory syndrome as one of the differential in the patient. Like this is the list of different patients which are diagnosed in our cohort with the systemic autoinflammatory syndrome. These are very complicated disorder, but if we think out of the box, then we can we can reach to the this kind of diagnosis. So when to suspect autoinflammatory disease in arthritis? So to summarize a few points, we should think about autoinflammatory syndrome or immune dysregulation with autoinflammation in arthritis when there is recurrent fever, recurrent infection, or multisystemic involvement with interstitial lung disease, evidence of gut inflammation, presence of gangrene, cytopenia, oral lesions or oral ulcers, with or without family history. And if there is very atypical clinical profile over the period of time with the recurrence, with the periodicity, then definitely we should think about this kind of disorder. As you can see in the picture, the degree of autoinflammation and autoimmunity, they have different pathophysiology. So if you take some disease that may have some degree of autoimmunity and some degree of autoinflammation, like some monogenic autoinflammatory disease like A20 haploinsufficiency, familial Mediterranean fever, they have maximum amount of autoinflammation. Whereas if you see example of ALPS like autoimmune lymphoproliferative syndrome, and then there is predominantly autoimmune manifestation with very low level of autoinflammation. But sometimes there is mixed features like in the psoriasis, lupus, myasthenia gravis, ANCA-associated vasculitis, there is mixed picture. So to summarize all these points within 2 lines, we can summarize like if there are multisystemic presentations or unexplained non-neoplastic recurrent or periodic issues, then we must think about inborn of immunity or immune dysregulations disease. So if these are persisting, periodic, pattern, recurrent, too frequent or too severe, too long lasting, unresponsive, multisystemic or uncommon complications, then these are the clue to think about inborn error of immunity or immune dysregulation in the patient. So to conclude, multisystemic presentations, we must think about inborn error of immunity as one of the presentation, one of the differential, and uh, it is a promising field. So in the complicated patients, we should not only think about the antibiotics and repeated X-ray and scans only. We should think about the holistic diagnosis, and the part of it may be one type of presentation. Like pneumonia can be one presentation of inborn error of immunity. Colitis may be one presentation of inborn error of immunity. And if we think about this out of the box diagnosis, and if we come to the diagnosis, then it will help for the timely therapy. So, blanket therapy of steroid in the inflammation may not be the good choice in all of the patients. And there are challenges definitely, but if we timely diagnose this disease, this will not only save the organ, it will also help to save lives. And child's body is completely different and should not be treated only on the basis of symptoms or on the basis of organ. Just like in this picture, if we see the same jungle from below, above, we will see only few trees and we will be limited on the tree. But if we see just like a bird, we can see the pattern in that jungle. So sometimes it is said that sometimes when we are too close to a tree, we will miss the view of forest. So if we see the view of forest, that pattern of the forest probably help you to diagnose which forest is this. So that forest is invader of immunity. So when you hear about the hoofbeats, this may not be horse always. This may be a zebra. So think of a zebra when you hear about hoofbeats. So rare diseases are not always rare. They can be around you when you think about it. Thank you, all of you. And now I would definitely welcome your queries and questions. And I'm really thankful to our organizers, and over to Dr. Dilly.
Thank you so much, Dr. Bhattrai. This is very good overview. I would like to have a few questions. Would you like to just, stop sharing your slides, and we would take the questions
Yeah.
and have our conversation. Right, what you summarized beautifully. This is really nice overview. Thank you so much for your time. As you rightly said, our eyes, don't see what the mind don't know, right? When our mind doesn't know, then there's no way our eyes would see. That was a perfect picture. I'm curious, right? I'm also a pediatrician and cardiologist. I don't practice immunology. In terms of incidents, if we were to give the overview to our colleagues who are practicing and taking care of children in Nepal, what's the number, estimated number, based on the published data and the incidents that you shared, would be how many children tentatively walking around us in Nepal?
Yeah.
I know
Yeah.
there's a data, but I just wanted to roughly give the scenario to see that how likely, as a pediatrician or a medical officer, sitting in the outpatient clinic or seeing a child in the hospital ward, what's the chance of me seeing a child with immunological deficiency? Can you shed some lights on that, please?
Yeah, yeah. As I presented, like if you see the prevalence from different countries, it varies from 1:500 to 1:10,000, depending upon the country. Like if there are no immunologists or there is very low index of suspicion, definitely the rate of diagnosis is low, and these are not reported. So for Nepal, as far as I know, there are not very much reported cases of invulnerable of immunity. This is again because of the lack of subspecialists, lack of diagnostic facilities. So and also the poor affordability of the patient. With the data which is available with me since the time of 2021 to 24, in the span of almost 3.5 years, I have 200 genetically proven cases of invulnerability of immunity, and I have almost 300 patients. This is a very rough and crude data. 300 undiagnosed patients, because they don't have money to do the test, because most of the tests are very expensive. Even a simple lymphocyte subset assay with the T, B, and NK assay, it costs around 9,000, 10,000. So I have a huge number of patients who are not diagnosed, and because they could not be diagnosed, some of the patients have left Nepal and went to a nearby country, and some of the patients probably remained out of contact. So in nutshell, they are quite underreported in the country like ours. And I think in the population of 30 million of Nepal, this figure of 500 is quite low. So I think many patients of invulnerable of immunity are undiagnosed
Thank you.
in our society.
Thank you. So I was just thinking about, the data that nearly 500,000 children are born in our country every year now. With that data, I was thinking that, we'd be seeing almost 1,100 children are being born every year. 1,100 children are being born every year. And with the data that you're showing, that estimated, right? I'm just giving with the 1 in 500 that you shared, that number, 547,000 children being born. That's the data of one of the year in last couple of years that I have. Like almost close to 1,100 children are being born with the immunological disorders, right? So we have not even 1,000 pediatricians registered to Nepal Medical Council so far. With this data, a pediatrician sitting and practicing in the outpatient office, what's the chance of him seeing a child with the immunological deficiency is extremely rare, right? You see 100 patients, you may not see. So
Yeah.
if we take this, being born 1100, 1000 pediatrician, my simple layman calculation, I was just thinking one pediatrician, one immunological deficiency with that rarity. I mean, very crude way of seeing the newborn,
Yeah.
okay? So it's extremely rare. The way that I wanted to share this to our audience is that it is a rare condition. But unless we suspect or unless we open our eyes and think that it's a possibility, there's no way that we could diagnose this condition, right? So I really share that value. So it's rare, but it's around, and we're close to 1,100 children with the published data around the world. We don't have the Nepalese data. Thank you for you keeping the number and tally, and hopefully with the NEPAS having an immunological chapter, and hopefully we'll have the registry of immunodeficiency conditions in Nepal, right? I mean, that will help us to get more. So now I have other question. That estimation is rare, right? So what are the tests that are really simple and available, and what is the struggle that that you face as a practicing immunologist in Nepal to get this test, right? We have a supply and demand, right? How many patients are being referred to you versus needing
Mhm.
the test, and so so if you need any genetic diagnosis, you draw the
Mhm.
sample and send it
Yeah.
to other countries.
Yeah.
That's the
Yeah.
okay.
Coming
Um,
to your first question, yeah, please.
Go ahead. Yeah.
Yeah, coming to your first question, like how do we test, like which are the simplest tests? First thing I want to focus that the test of immune deficiency is quite complicated. Like there is the concept like if the patient has
Sorry, I think someone is.
yeah,
I think.
yeah.
Let me. Who is making the noise? I'll just take it out. Go ahead.
Yeah. So for the test, the simplified test which are available in Nepal currently, after I arrived, after my studies, I have also exercised a lot to make them available in at least in Kathmandu. The You can take example of immunoglobulin profile, lymphocyte subset by flow cytometry, complement assays like C3, C4, CS50, and C1 inhibitor level. And I have myself started to work on the nitro-blue tetrazolium test, and we have also the facility of DHR by flow cytometry, and also other tests to check for the autoimmune features like ANA, anti-dsDNA, ENA profile, extractable nuclear antigen test. These are available in our setup. But even the sometimes even simpler test like CBC, peripheral smear, and neutrophil assays, these can also help, like for the disease like leukocyte adhesion defect. And one thing I want to add in at this point in your first question is, like there is a trend of checking in immunoglobulin profile in Nepal to the patient who is suspected to have immune deficiency, and if it is found to be normal, then generally it is thought that they don't have immune deficiency. It's not a true assertion, because immunoglobulin level are low in very limited number of invernador of immunity. So we should not think that if the invernador if the immunoglobulins are normal, then there is no immune deficiency. It's not true. So immune deficiency diagnosis is quite complicated, but simplified test may not always help you to reach to the diagnosis. But sometimes even the smallest clue, like if you have the patient with huge neutrophilia with non-healing non-purulent skin lesions, you may think about leukocyte defect. This kind of clue may be there. And second question you have asked was about struggles. Yeah, there were significant struggles for me when I returned back, because there were no diagnostic facility as well as no treatment facility in Nepal. So I think Dr. Dilli, you can mute Dr. Rajesh, because there are some automatic
Yeah,
sounds.
got
Yeah,
it. Got
thank
it.
you.
Done.
And these struggles for diagnosis and therapeutic measures was huge, because even after I diagnosed some patient, there were challenges of treatment. So definitely there were challenges, and there were struggles for making these drugs available even for the immune dysregulation and rheumatic disorders. But now most of the oral drugs are available within our country, and still I'm doing my best
Thank you.
to make other injectable drugs available in Nepal, with the talks with the authorities, ministries, and everybody's. But the most important thing, most painful thing that is hitting on me is the
On
affordability of
which
the
baby?
patient.
The triplets. I
Yeah.
haven't. How big are they? They
So
are 33 weeker.
uh, Dr. Dilli, yeah.
Yeah, he is muted.
So the struggles are many, but now I think
Okay.
that most of the patients who are from the very low socioeconomic background, they cannot do any test. Even they cannot do the CBC and peripheral smear. At that point of time, I really get like I I don't have any clue like
Thank you.
how to proceed on this
Yeah.
kind of patient. So these are the
So
real struggles in front of me. But if there are some efforts from government or medical institutes and some fronts, maybe NGOs also, and the efforts
yeah,
like you have done in the field of cardiology, then definitely there is a
the
bright
thank
place.
you,
I
Dr. Bhattrai. I think we have a question from Dr. Bhattrai. You kind of answered some of his question.
Yeah,
That was
yeah,
essentially when you diagnose, what's the management, right? How are we managing
mhm,
the inborn errors of immunity management in Nepal? Looks like what treatment options are available. I think you answered some of those questions already. The challenges that you have, so what I got is doing the immunological profile on itself and getting a normal immunoglobulin doesn't mean that we have ruled out the immunological problems. When there's a
yeah,
clinical suspicion, the specialist needs to see. I think that is a really good point to take from here. Then I was like, I already asked that question, right? I'm already, whenever I attend this seminar and webinar, I get nervous of me seeing a patient and missing a patient, right? Because, oh, is this child, does this child have an immunological disorder, right? And then every infection, the child can have that, right? Every infection, could it be due to immunological deficiency, right? Is there a number of infection or is it just a
yeah,
multi-systemic infection that we count? I know you tried to provide me with that your criteria, on
yeah,
those publications, but I'm a busy pediatrician, right? I don't have time to go to those updates. Is there any kind of number that you would say that, okay, if it's multi-system involvement or multiple infection, you guys have to
yeah.
think.
Mhm.
Is there anything, any
Yeah,
number that you would help us to?
just to simplify the answer, because if I described all the EC and JMF criteria, it will be complicated. So to simplify the matter, I always reiterate this thing in the multiple presentation. If the presentations are multisystemic or recurrent or persisting or periodic, these four things, if this kind of patients comes to you with the huge pile of CT scan, X-ray, and CBCs, and there is no diagnosis, then definitely it is either malignancy or enteropathy or endocrinopathy or immune deficiency. So these are the four used topics. So enteropathy and endocrinopathy you can diagnose. So remaining two are malignancy and immune deficiency. So it is quite clear. So if you have multisystemic, persistent, recurrent, and periodic features in any children or any adult or any adolescent, this should raise the suspicion of immune deficiency. One. Second, you ask the frequency, though there are the frequency of ear infection is 4, but in general, I would suggest except URI, except UTI, except URI, UTI, and infection in NICU, like neonatal sepsis, any other children having two deep-seated or systemic infection, having two episode in a year, more than two episode in a year, in general, this is not a criteria, but if I say like this, it will fulfill all the criteria, almost all the criteria. So if there are more than two episode of systemic infection, but it should not be only URI, viral infection causing upper respiratory infection, UTI, and neonatal sepsis in NICU or ventilator associated infection in PICU. Except these four, if there are severe infections or more than two episodes of deep-seated infection or any kind of blanket infections in the child, and you don't have any particular clue for this cause, then you should think about immune deficiency. And one third remaining thing is, if you have very unusual organism in very unusual frequency or very unusual severity, then you should think about immune deficiency. And fourth and final is any recurrent like tissue swelling, mass, or any other recurrent issue in systemic in multiple systems which does not have any clue, then you should think about immune deficiency. So generally, if you don't have any diagnosis after 2-3 visits to a doctor, then you have very few possibilities, and one of the possibilities is immune deficiency.
Thank you, Dr. Bhattrai. I have allowed Dr. Bhattrai. Do you? I'm not sure whether your questions were answered. If you would like to ask, if you could talk,
Yes, please.
Yes, no, my question was answered. That was really a great talk. Thank you very much. I think a lot of the listeners would probably learn a lot from this talk. Thank you very much.
Yeah, thank you, Ruben, for joining. And I have a couple of more questions in terms of more of so yes, I suspect I'm in Jumla and I'm seeing a child who isn't admitted. I suspect a case. Are you saying that I transfer this kid to you, or are you available on the phone, or is there any way that that consultation can be done virtually? If I have doubt, can I call you? I mean, that's my simple question, right? Second is, how many immunologists are there that every pediatrician or every healthcare worker start calling them? Would they be able to provide that, virtually? I mean, I would like to hear what is your way of filtering if people want to come up. Are there any thoughts on that?
Yeah, definitely. Like I am here in my country from last 3.5 years, and till now, probably because I am yet to reach in the corners of the country, I do not get much referrals. But definitely, I must say that I am getting more and more referrals, and I would like more and more pediatricians will be interested in these subjects, and more immunologists will come back to our country after training. Till now, I'm directly connecting with the different physicians or pediatrician. Like currently, also I get call from very remote area like Darsula, Acham, Gorkha, and they are very familiar uh, with my suggestions, and sometimes we do make a video call, and I give them very simple suggestion. Like I don't tell them very complicated thing, because if you tell the exceptions, then it makes a confusion. Like if you tell mean platelet volume may be normal in Wiskott-Ehlers syndrome, this is very confusing thing. So I always tell simple things, like if you have viral infections or multiple different opportunistic infection, think about cell-mediated immune deficiency. And if you have encapsulated bacterial infection, that may be humoral immunodeficiency. And sometimes I conduct different doctors meeting, and I share different kind of case
Yep.
presentations, and they learn from this. And phagocytic defect from catalase positive organism, staphylococcus, tuberculosis, candida, aspergillus, all these kind of simple simple informative things. And second thing, sometimes a simple test can give a clue. Like if you don't have malignancy and patient's neutrophil count is 50,000 and he has skin lesions, that can be leukocyte adhesion defect even without any test. So sometimes it is quite clear, but sometimes it is quite complicated, like activated PI3 delta kinase syndrome. This kind of disease cannot be diagnosed in Jumla or any other district, even in Kathmandu. So definitely, immunology is an expensive subject with expensive test. So most of the disease definitely need the extensive workup, but most of the time I give them a blanket suggestion, like
Yep.
you can
Thank
give
you.
at least antibiotic
Yep.
prophylaxis, and at least you can be aware about the what other immune dysregulation can happen. Like if you have suspicion of autoimmune lymphoproliferative syndrome, I will make them aware about
Thank
splenomegaly,
you.
anemia, all these
Yep.
kind of things. So generally I would like to, because I am alone currently, I currently individually
So
connect in
the
the telephone, but
thank
I
you.
am trying my best. Yeah.
Sorry, I have another question. I was not trying to interrupt you, but I have another question from, I think,
Yeah, yeah,
on the
please,
similar
please.
background, Dr. Anup Singh, from western part of the country. Dr. Anup, would you like to share your question here? I know you shared in the chat box. I will allow you to talk. That would be more precise for our audience, who are listening from around the world. Go ahead and ask your
Yes,
question or
please.
provide your
Yes, Dr.
comment.
Anup, you are welcome.
Let's see. If he is well, his question was more
Yeah,
about the financial challenges of the people
yeah,
who would want to get to Kathmandu, right?
yeah,
I think we may not be able to solve this issue through this webinar,
yeah.
but it's
Mm-hmm.
beyond us. I was thinking the same thing, right? You have to invest so much time in history taking and taking care of this patient, and even your consultation fee based on whatever is determined by the government of Nepal, or the same for, I don't know how the specialists are charged in Nepal. Is it special for super specialties, or a specialty or general practitioner? Are there three or
Yeah,
four different categories of payment or no? I don't know. I'm just curious about that. You want to be paid for your work, right? Number
yeah,
one. The second
yeah,
thing is the test, and test that what people can afford or cannot afford, right? That's the rare conditions like cancer and heart conditions are being, we hear from the government circulations that, they are being free, or certain extent of subsidization is there. Is there any attempt to get this immunological disorder on that category,
yes.
right? That's that.
Mhm.
Um, Third is most importantly, I was just thinking that, I mean, how many immunologists are there, right? How do we stratify to come to you? So these challenges, is there anything from our perspective, from our part of the world where we practice, you have traveled many parts of the countries, is there anything that
Yeah.
we can do to help or work
Mhm.
together? So from,
Yeah.
I wanted to
Mm,
just hear from you directly
mhm.
rather than
Yeah.
assume.
Yeah, I think you are right. I completely agree with your statement that this thing cannot be solved from the physician side. This should be nation's responsibility, because if you see country like India or Sri Lanka, even in Bangladesh, the country almost in 28 states of India, the Indian government provides IVIG free of cost to all of the patients, and they also provide I think I'm not very sure, but they provide some amount of money, just like Nepalese government provides the different amount of money for the kidney failure patients and cancer patients. In the Indian government, they provide the fund for rare disease also, and immune deficiency. Indian government has kept under the list of rare disease, and Indian patients are quite being benefited from that. But in Nepal, I tried to visit higher authorities also. Till now, I'm not successful. I'm trying my best, but yeah, Dr. Anup's point is quite right, because even for some patients in Mustang or Umla, Jumla, and all these sites, even at the city like Chitwan or any like Gorkha, they cannot do the test, immunological test, or some expensive test like ENA or any other test. So without test, we are not allowed to start any medication, even we have strong suspicion. So there is no solution for this. But
Thank you.
what we can do is, probably we are gradually progressing ahead, in because Nepal Pediatric Society has just established now the pair pediatric allergy, immunology, rheumatology chapter. Probably this chapter will also make some progress. We are working on that, and we will develop some guidelines and protocols which is very simplified for every physician. We are working in far western and far eastern, every part of the country. They will be benefited first. Second thing, we must develop some kind of center, or some kind of foundation based test. Otherwise, no person can afford these expensive drugs or expensive tests, and this is a major challenge. That's why most of the immune deficiency patients in the country like ours remain undiagnosed. This is the major setback, but there is no direct solution with us. Currently, we are only, this kind of webinars are focused only to raise awareness within pediatrician, and the main focus is, like, there are some inborn error of immunity which are not very serious. Like, for example, I gave you the example of some of the chronic granulomatous disease patients are very having mild presentations, and they can uh, do well in the antimicrobial prophylaxis. And some of the XLA patients, and XLA patients are doing fundraising from different social media, and they are getting IBIG help from some philanthropic society. So if we can diagnose these patients, then we can bring a change. Like in the setup like very far western Nepal, if you can do the immunoglobulin profile and they are very low in the multiple test, probably I cannot say for definite purpose, but probably that is humoral immunodeficiency, like X-linked agammaglobulinemia or common variable immunodeficiency. And even you, if you cannot do any kind of genetic test or lymphocyte subset, you can give IVIG safely. So, but again, it is expensive and there are obstacles. But that is the purpose of this kind of webinars. Yeah, definitely there are obstacles, and there are many struggles. Like I sometimes feel really sad when the patient does not have anything in their pocket, and they just say that, doctor, give the drugs. I cannot do any test. And in that situation, I cannot diagnose also. Even after having all this training and knowledge, we cannot do anything. And no one can do any immunological diagnosis without any test, because that is illegal also. Because most of the drugs have some, may have serious side effects, and we must have the definitive diagnosis. So we should think everything. I think probably government will listen all these plia, and they will include immunodeficiency within the column of rare disease, and they will start helping just like kidney failure patient. That is the
Thank
only
you.
solution I see.
I think I could see, I could feel the pain. I could see your passion. I mean, amazing, Dr. Bhattrai. Just to see how you have change, and it's the positive impact that I'm so glad that Nepal Pediatric Society as having a chapter, sub-chapter with this new team, have done multiple chapters, and I'm glad. I think with this, the voice will be heard, and you do continue to do what you've been doing, right? That's great. And then there's one quick, I mean, Doctor,
Yeah,
I think
Dr.
if
Rajesh
they
has
want to,
raised
I'm gonna
yeah.
have him talk. Before that, where and how can they refer the patient to you? Where are you best? So that people can easily get to you. That's one of the things that was, I think Dr. Bhattrai asked that the audience might want to know,
Yeah.
how they refer to
I'm
you.
really open to the patients, and I always try to help patients, and they can directly contact me. And
Where?
I'm
Which
very
center?
familiar with. Yeah, it's a private center in Kathmandu. Am I allowed to take
Yeah,
name of
absolutely,
private center?
absolutely,
Okay,
absolutely. Wherever
I
you
work
are,
in
I
home
mean,
hospital
okay,
currently. So there, like I admit the patients if needed, and I avoid admissions as far
okay,
as possible because that will increase the cost. So I try to solve everything in OPD basis, but very rarely they need admission.
okay,
So I am available in Kathmandu, and I am trying my best to establish a connection with the far western medical colleges now, but they are not accepting me till now. I am not asking for any
okay,
money or any salary or anything, but I am trying to establish some classes and academic programs, at least
yeah,
1 or 2 days
okay,
in a month. In the near future, probably I will be successful. If I am successful, then in the Purvanchal, like province 1 and
yeah,
maybe province 6, I
okay,
will be there in one of the medical college, and probably the patients, because some of the patients do not have even the fare to come to Kathmandu, travel to Kathmandu. So that will be easier for the patient. And you can share my number also. I don't mind.
okay. Thank
And
you.
definitely with the physicians and pediatricians, I am really trying my best. And after establishment of this pair chapter, you can find all of my detail in NEPA's website.
Um, Sorry, I think
Yeah.
Dr. Rajesh, you wanted to say something?
Yeah, no, I mean, I learned a lot. It was very educational uh, seminar, and thank you for sharing your knowledge, expertise, and experience. And I applaud you not only for doing the clinical task, but also trying to establish the Center for Excellence in terms of managing this kind of condition, as well as developing the system for by education, advocacy, and working with multiple stakeholders. And I respectfully disagree when you say we cannot do much because you have done so much. And from here, I can see you working more and more. And if there is anything we can do to help your missions and cause, we are always here. I'm just here to say thank you so much for your time and sharing the education and the experience.
Thank you so much. Like it is really an inspiration for me. Like the even your words, encouraging words are like they mean a lot for me because in the beginning when I returned back from India and USA training, and then I was little bit frustrated because I had nothing. But now gradually. The colleagues like pediatricians like all of you have supported me, inspired me, and I'm trying my best. But now I'm really hopeful because we have successfully established pair chapter in inside Nepal. So now it will get momentum, and I think the immunophenotyping and genetic tests are the real challenges for me in the beginning. Till now, we don't have any support from any sites for that, and if we get any kind of supports from any foundation or government or any society for the genetic test, even that would be a great help for patients because it cost almost $250 per test per genetic test. So that is a huge challenge for us. I'm trying my best with the different foundations. Even in USA, in this recent visit also, I tried with Immunodeficiency Foundation, Jeffrey Model Foundation, and many other foundations which are working for primary immunodeficiency disease, but they are primarily supporting the US-based institutes. But I'm trying my best to do as much as possible for our patient, because currently also in my Excel sheet there are 325 patients. I do not have any whereabouts and recent data about them, because they may be, some of the patient may have died also, some of the patient may have fled to India. But I want to at least diagnose these patients, because I have seen that after diagnosis different avenues open. I had one patient of Griscelli syndrome from Chitwan, and this Griscelli type 2 is devastating. Griscelli type 1 is not devastating, but type 2 is devastating. And they raised a fund on Facebook, and the patient is now being transplanted in one of the reputed Indian institute on my effort. So if we diagnose, probably that opens some avenue for patient, and for these parents that is really blissful and blissful. So your words, like Dr. Dilli's word, everyone's word is um, a huge support for me, huge inspiration for me, and it means a lot for me. And thank you for supporting
Yeah,
me.
absolutely. Yeah, we are always here to help the life of children in Nepal, and we are always helping as much as we can do. And believe me, when you have so many engaging, active audience spending their time way after the meeting time is over, I mean, you have a lot of people behind you. We can always continue to talk offline, and I think with that, we will like to wrap up the event for today. I, on behalf of Prerana CME Planning Committee, would like to thank Dr. Bhattrai, the presenter, and all the audience who's been here participating very meaningful and actively. And we will support your work. We will be in contact in the future as well. And with that, we will see you all with the next topic in a month, which is again will continue to be on the third Saturday of the month. So that would be December 21st. Until then, I'd like to say bye-bye. Thank you all.
Thank you.
Thank you.
Thank you,
Bye-bye.
all of you.
Namaste.
Bye-bye.